Hello, everyone. Welcome to tonight's Google Hangout. It's a rapid response to the drcr.net Protocol T results and its impact on patient care. And we've got a really great assembled cast of doctors with us this evening. As a way of introduction, this live roundtable is supported by an unrestricted educational grant from Regeneron and does not carry any CME credit. However, in the coming days, you can log on to MedPage today and claim your CME credit. My name is John Kitchens. I'm a retina surgeon with Retina Associates of Kentucky in Lexington, Kentucky, and an adjunct professor of ophthalmology at the University of Kentucky. I'm joined tonight by Dr. Andrew Moshfeghi from the USC Eye Institute. He's a retina specialist and a good friend. We also are honored to have Dr. Vivian Fonseca, a real thought leader in endocrinology and diabetic retinopathy from the endocrinology standpoint. And finally, Dr. Paul Karpecki, who is a specialist optometrist and director of the Corneal Services and Ocular Disease Research Section at Kauffer Vision Group here in Lexington, Kentucky. Paul is also the chief clinical editor of Review of Optometry, and really no one has their finger on the pulse of optometry and diabetic screening like Paul. So as way of disclosures, we can see the disclosures of each of our faculty on the following slide. And when we look at the learning objectives for tonight, we really want to learn how to discuss with patients the impact of diabetes on their eyes, discuss strategies to ensure patients receive baseline and annual dilated eye examinations, identify treatment options and therapeutic outcomes from the most recent drcr.net Protocol T study of comparative effectiveness for various anti-VEGF agents for diabetic macular edema, and learn really how to coordinate a referral and follow-up plan for patients with diabetes and their eye care specialist. So looking just a little bit about diabetic eye disease, nearly 30 million patients in the United States have diabetes. Among them, 7 million of these patients have diabetic retinopathy, and diabetic macular edema is the leading cause of vision loss in working-age adults in the United States. However, despite all of this, fewer than half of all diabetic patients are receiving their annual dilated eye examinations. And we know that vision loss from diabetic macular edema is largely preventable, and as we'll see from the Protocol T study, eminently treatable in many instances so long as we get to it early on. Just a few words about the DRCR, or Diabetic Retinopathy Clinical Research Network. It's a collaborative network looking at diabetic retinopathy, diabetic macular edema, and other associated diabetic eye diseases. It was formed in 2002, and we have more than 100 participating sites with more than 320 physicians in the United States. And it is funded by the National Eye Institute, which is a subdivision of the National Institutes of Health. And to date, more than 20 studies across all areas of diabetic retinopathy and DME have been looked at courtesy of the drcr.net.
Yeah, I mean, there's
so
not
much.
I really gotta pay attention here.
So
okay.
Let's start and let's look at the Protocol T design. Dr. Moshfeghi, I'm going to turn it over to you. Tell me a little bit about the Protocol T.
Thanks, John. Well, the Protocol T was a diabetic retinopathy clinical research network study, as you mentioned. It's a prospective, interventional, randomized clinical trial which evaluated the treatment of diabetic macular edema in patients 18 years of age or older who had center-involved diabetic macular edema as determined on optical coherence tomography. And these were patients who were treated with 3 different anti-VEGF medications intravitreally over a 2-year period with a 1-year endpoint. And the question of the study was there any significant difference with respect to visual acuity when treating these patients with intravitreal aflibercept versus intravitreal ranibizumab versus intravitreal bevacizumab at 1 year? Visual acuity was the primary endpoint, although multiple secondary endpoints were also explored.
So Andrew, give me an overview of the top-line results of the DRCR study.
So when we look at mean change in visual acuity at 12 months, the top-line data demonstrated that aflibercept patients had 13.3 letters gain in visual acuity, which is a little bit over 2 lines of visual acuity on the ETDRS visual acuity chart. And this was compared with about 9.7 letters gained for the bevacizumab group and 11.2 letters for the ranibizumab group at 1 year. There did appear to be a change in the results when we look at different balances in baseline visual acuity. For example, when you look at patients with pretty good visual acuity in the 2032 to 2040 range, we see that the differences that were favoring aflibercept start to melt away, and we start to see more equal distribution of visual acuity improvements, such that 8 letters of visual acuity were gained with aflibercept, 7.5 with bevacizumab, and 8.3 with ranibizumab. Interestingly, when we look at patients with worse baseline visual acuity, as you see on the right-hand side of the chart, we see that the aflibercept group had 18.9 letters of visual acuity gained versus 11.8 for bevacizumab, ranibizumab. So it really seems like this lower strata of baseline visual acuity favoring aflibercept seem to be driving the overall aflibercept benefit that we see on the top-line data.
Andrew, it looks like on these graphs that patients with better visual acuity don't do so well. Is that true?
Well, it's not that they don't do well, but of course they have a ceiling effect. You know, 20/20 we think of as normal or perfect vision for most patients. But patients in the lower strata visual, or the upper strata visual acuity, depending on how you look at it, could have had 20/32 vision or 20/40 vision. So there's really not as much room for potential improvement for the patients who started off with better vision.
And do you think most of the patients that you see on a routine basis in your clinic, are they more often patients that are 20/50 or worse or 20/40 or better?
Well, it's interesting, you know, when you think about it, we see a lot of diabetic macular edema and poor visual acuity, and sort of your gut instinct wants to say that, you know, we're seeing patients with worse visual acuity. However, when you look at the data from the ETDRS study, as well as diabetic retinopathy clinical research network studies, we see that roughly 75% of patients or more actually have visual acuity that's 20/40 or better.
So when you look at these results as a whole and broken down into better and worse visual acuity, does it change the way you're gonna manage your patients? Are you gonna do anything different tomorrow than what you did today?
It's a great question, John, and I think that was one of the whole ideas behind this study. And really, I think what the study shows us is that, by and large, there really are not clinically meaningful differences between these 3 agents for the majority of our patients. And so really the answer is going to be no, I'm not going to change much in the way that I approach these DME patients. In fact, I'm going to be reassured that really with whatever agent I have access to within the constraints of our complex medical system here in the United States, I can know that I'm offering my patient a very strong therapeutic option.
Great, thank you, Andrew. Now we'll move on to Dr. Fonseca. Dr. Fonseca, when you look at these top-line results from an endocrinology or a diabetology standpoint, do they change your thoughts about our patients with retinopathy? What are your take-homes from that standpoint?
Well, I think this study is important for a couple of reasons. One is that this is a true comparative effectiveness trial comparing different therapies. It's something we look at in diabetes therapies a lot. Secondly, it's looking at something that's important from the patient's perspective, visual acuity. It's not changing the natural history preventing diabetic retinopathy. That's the traditional way that we endocrinologists look at retinopathy. We want good control right from the start so the patient never gets retinopathy. The reality is that there are people out there who are losing vision, and that's a very late stage. We want to prevent that. But if they do get that, it's reassuring to see that there is treatment that can help them.
You know, we've had some recent studies, Dr. Fonseca, that have shown that patients are struggling to understand how diabetes affects their eyes, and they're struggling to get referrals. In fact, in one recent JAMA ophthalmology article, among patients with diabetic macular edema, only about less than 50% actually report being told by their doctor, by their primary care doctor, that the diabetes had affected their eyes or that they could have retinopathy. Can you talk a little bit about our patients and our primary care's lack of awareness of retinopathy or lack of understanding of it?
So first of all, it's very clear in the ADA and other guidelines that patients with diabetes should have an annual eye exam. These should start 5 years after diagnosis for type 1 diabetes and at the time of diagnosis for type 2 diabetes, since patients with type 2 may have had the disease for 4 or 5 years and not known it. So that kind of surveillance is very, very important. Now, the challenge that we have is telling a patient to go and have an eye exam doesn't necessarily mean that the patient actually goes there. Second problem is access to an ophthalmologist, particularly people with expertise, such as all three of you. It's not always available. So there are a number of studies showing that there are alternative ways like fundus photography, telemedicine. All these tools are available today. And I would encourage everybody who's listening today, who looks after people with diabetes, to strive for at least over 80% annual exam rate, if not 100%. And you can find ways to do this.
Greg, what are some suggestions? What are some ways that you found effective to make sure that your patients obtain that valuable follow-up?
So one particular way that we are doing this now with electronic medical records is to give people reminders. It started with reminders for the physician that your patient hasn't had a documented eye exam in the EMR. We're soon going to go to patient reminders. So the patient could get an email saying, you haven't been for your eye exam. Here's the appointment that is made for you. So all these kind of cues are very important. When people have chronic disease, they tend to ignore these things. They put it off. What should be 1 year becomes a year and a half, 2 years. And after about 5 years, when they've gone to the doctor, they haven't had any abnormality, they tend to get complacent. And that's probably the most dangerous time.
That's certainly an issue. You know, from a reverse standpoint, if we look at patients who have DME, the majority of those patients, or almost 50%, I should say, report not having seen a diabetes specialist. So where is the margin? Where should a patient go from seeing a primary care doctor to having an endocrinologist or a diabetologist?
Well, there are not enough endocrinologists in the country to see all the millions of people with diabetes. So that's not a realistic thing. So we've got to have care provided in the primary care setting. But I'm a little optimistic now that with the kind of records we have and the metrics that are being used in terms of pay for performance, checking A1C, looking at the feet, structured entry in records, that at a population level, we're going to try and address this issue. I mean, it's still surprising that in a country like ours, 50% of patients don't have the care that they need.
Amazing. Thank you, Dr. Fonseca. We'll move on now to Dr. Paul Karpecki. Paul is a colleague of mine, an optometrist here in Kentucky, and really has his finger on the pulse of optometry, which is really critical in the screening of these patients. Paul, talk a little bit about the role that optometry plays in evaluating diabetic patients and ensuring that they get the annual screenings that they need.
Well, the timing's perfect, John, for this question because it follows very nicely on Dr. Fonseca's comments about there's not enough endocrinologists, and that's a fact in the United States. In fact, there's probably even a shortage of ophthalmologists. At least that trend will continue over time, given the number of cataract surgeries. But optometry, there isn't a shortage. They kind of serve more of a primary care opportunity here, and because of that, that's really where the patients that are being seen most often are most likely to go to their eye doctor are going to show up in an optometric office. I think I saw some statistic that showed approximately 70% of all eye exams were performed by optometry. So it's just natural that the majority of patients would go to that because it's an easier opportunity. There are the patients already part of that practice that might develop diabetes, and you just look at the population growth around that. So I think optometry has to take a significant role in this, and I think they are, but it becomes very critical now. And this information and studies like this really, I think, bring that to the forefront and make us realize that not only can we do something about it, but we can have a pretty dramatic effect even in patients who have vision that's worse than 20/50 by knowing such the protocol T results and knowing when an appropriate referral to a retina specialist should take place.
And what do you think optometry as a whole, your basic optometrist out there on his own, should take from the protocol T when you look at the data?
The first thing that stands out for me, I think we should take is number one, that these regimens work. That's the most exciting thing. It doesn't matter what level the patient's at. You're going to get results that work a significant amount of the time. These patients all had quite a bit of improvement in vision, 9 lines or 13, depending on which medication, which VA they began with. It certainly stratifies even more. But nevertheless, the fact is that one, you got to know that it works. And I think this is another verification. Now, there's other studies that have kind of shown this, but DME is one that I think we were looking for data around this in particular and around diabetics and trying to understand it. Number two, it's such a huge population of patients. And I've seen estimates that say that the diabetic population is growing by about 6% per year. And so, we're naturally going to see more. And so the results of this tell us, one, we see more patients, but we know that there are some treatments that can happen. And I think the third thing that really stood out to me was a little bit of what was brought out at the beginning, that there's 7 million people in the United States with diabetic retinopathy. Probably estimate about 2 million potentially have DME, but yet we're not treating even half, maybe even a quarter of those patients at this point. I mean, we need to be looking for those who are under 20/40, and of course those who present above 20, worse vision 20/50. I think they're going to stand out naturally, but we have to be aware of this as the leading cause of decreased vision related to diabetes, or in the population as we see as a whole, is diabetic macular edema. And number two, we have to realize that we can do something to improve that vision if that is the number one cause playing a role. So I think that stood out. One, that it worked for all. Number two, you can have an impact on almost all levels. Number three, there was quite a bit of difference. The worse the vision, you could see even more of an improvement, especially in one particular drug there, the Fabricept. And then finally, the importance of diagnosing these patients early and getting a treatment response, because we could see that happens.
And Paul, what do you think as far as communication? What is the best way to communicate with the primary care doctor?
I think it's just creating more awareness. I think that becomes very important. I mean, we know that, and this was really well said, I think Dr. Fonseca said this, that many patients they know they have to have an eye exam, but they may not, seek it, or they may not take the time or realize the importance of what this is showing. Whether it's the progression of the disease, whether it's confirming the diagnosis, a lot of things that we can see through retinopathy that is so valuable. In other words, what I mean by that is there's many patients who don't realize that even the first diagnosis of diabetes could happen in an eye exam, because there are certain signs, as we all know, in the retina, but most patients don't. And so I think in order we have to not only educate PCP, although they have a good understanding, but it's the patient, and the patient to understand the importance of this and the importance of making sure they receive access. They go to a general ophthalmologist or an optometrist, and they ensure that this is followed on a regular basis, and a reason for it, and what takes place. Now, there are we have some great PCP referrals I have in the area, especially where we're at. Really, they come in knowing their A1C, they come in understanding the disease, they know why they're there to have it, but I think it's variable, and it's variable from patient to patient. That relationship is fundamental, because most of those patients could be going around with slightly decreased vision, 20/25, 20/30. They may think it's normal, might be part of the disease. They might think, well, it could be my cataracts, and a number of these different potential scenarios. But the only way to really know is to get in for that eye exam. And if you think about the incidence of of DME. It's a fairly common culprit for decreased vision. And of course, there wasn't a lot of good treatments for it in the past. That's not the case, as came out with the Protocol T results.
Wonderful, wonderful. Well, we're being deluged by questions from the audience. I've got a few of them here. So for Dr. Karpecki, can a patient reverse their retinopathy with good blood sugar control?
Well, it's a great question. I think it depends on a number of factors. One, it depends on the severity of the disease and the level of which the control is. And the most important thing with diabetes, and I'm sure this actually can be answered a lot better by Dr. Fonseca, is that consistency in A1C, as opposed to really high, really low. So it's that variability that can have a greater toll. At least we see that even in the retinopathy of these patients, where I'll have a patient who comes in and I found that they're progressing in terms of their retinopathy. Now they're perhaps pre-proliferative, and I'll ask them, is your A1C right now? And they say, well, it's pretty normal, I'm about in the 7s. And then as we go into it, they say, well, I had times when it was extremely high and extremely low and extremely high, and that consistency is certainly there. So I mean, there's a lot of questions first that have to come into play. And then, of course, if it's proliferative, there's not as much of an effect that can be done. That certainly has to be managed by a retina specialist. And then also, but that being said, absolutely they have to take control and be proactive in this. And there are benefits. I've seen patients who have actually had, mild non-proliferative diabetic retinopathy that actually did, in my opinion, looking at it, decrease. And talked to the patient. They said, yes, I've been really working at this. I've been on a diet. I've been trying to control and watch how I eat, and I was complimented them and congratulated them on the improvement. So yes, it can make a difference, and it makes a difference in terms of the entire systemic body, but also the eye. But it also has to be done in a good controlled way, where it's at a consistent level. And number two, it also has to be, you have to look at the level which the patient is entering, and to know how much of that could be reversed, the stage of the disease or how long it's been present. But overall, yes, there's great advantages to being proactive, taking control, trying to get that to a good level. And yes, in many cases, you'll see some mitigation of the retinopathy in itself.
Great. Question from Bryce in Austin for Dr. Fonseca. Dr. Fonseca, is it true that retinopathy can worsen in the first year or two after a patient achieves good blood sugar control?
So this is a very intriguing phenomenon that was seen first in the CROC study and then in the diabetes control and complications trial, where there was a transient worsening. It actually occurred over 3 years. Worse in the first year, and then there was still some little worsening after that. And then the lines crossed at 3 years and things started getting better. It really is a telling lesson in clinical trials, where DSMBs sometimes want to stop a trial because they're seeing short-term harm, but what really matters is the long-term good. And I'm so glad that that study wasn't stopped, because it would have given us a very misleading answer.
Absolutely. Question from Darius in Palo Alto for Dr. Andrew Mashfegi. Andrew, does the cost differences in the medications outweigh the visual acuity benefits?
Well, it's a great question and a controversial one. Let's talk a little bit about the cost of these drugs. We have aflibercept at $1,950, more or less, per dose. And this is going to be compared with ranibizumab at roughly $1,200 per dose. And we also have bevacizumab, which is, one must remember, is off-label for intraocular use, as well as for the treatment of diabetic macular edema. Now, the reason that bevacizumab is so inexpensive is that it aliquots from a lot of bevacizumab that's used systemically. And because of that, there is some concern about compounding pharmacy, handling of the drug, and the potential for contamination. That being said, in the present study, purification studies were performed which showed nice consistency of the bevacizumab that was prepared, but in the have the performed routinely. So for some folks, this could be a concern when using this cheaper alternative medication with I think that the medical answer this question for us, but certainly there are individual practitioner level as well as the health insurance provider level that can help guide us to the answer of this controversial question.
And coming back to you, Dr. Mashfegi, were there any differences in safety in this study between these different medicines?
When we look at common ocular side effects such as subconjunctival hemorrhage and injection-related issues, we see that there really are no significant ocular side effects that were different amongst these different agents. Systemically, there's always a theoretical concern with respect to the mechanism of action of VEGF inhibition. We worry about arterial thrombotic events being elevated in this at-risk patient population. Interestingly, we don't really see any significant systemic serious adverse events that were different between the two. There was a post-hoc analysis that demonstrated when two different MedDRA classes, when we look at cardiac events as well as vascular events, that there was an increased rate of those in the ranibizumab group compared with the other two agents. But this was a post-hoc analysis and not one that was pre-specified. So it's difficult to determine whether this really had any meaningful difference systemically. So by and large, really no significant differences between these three agents, either from an ocular perspective or a systemic perspective.
One last question for you, Dr. Mashfegi, and then I've got a question for Dr. Fonseca. Do these medicines also affect bleeding or proliferative retinopathy in patients' eyes?
Well, not so much from this study, but what we've learned about these agents in our clinical practice and from multiple previous clinical trials is that there does appear to be a significant improvement in the appearance of the other features of diabetic retinopathy different than the diabetic macular edema. We see a significant decrease in the amount of intraretinal hemorrhages and cotton wool spots and microaneurysms when we look not only at the back of the eye but also in the periphery of the eye, such that another indication in the management of diabetic retinopathy was recently granted to ranibizumab in patients who also have diabetic macular edema, and we anticipate that a similar indication may be granted for aflibercept in the coming months, as they've been granted priority review and breakthrough therapy designation. And when we look at our patients who've been treated with off-label bevacizumab, we also see these similar benefits in our clinical practice. Hopefully we'll see additional subgroup analysis in the present study to help further buttress what we've already just discussed.
Thank you, Dr. Mashfegi. Dr. Fonseca, one question for you. Do glitazones and some other oral agents worsen diabetic macular edema?
There have been reports of that. It hasn't been seen as a consistent, regular effect, but there have been case series described with the use of glitazones. So if a patient has macular edema, you may want to hold off using the glitazone, but that doesn't mean that it cannot be treated, and it doesn't mean that it's common. On the flip side, that glitazones, as you know, are PPAR gamma agents. PPAR alpha agents like fenofibrate have been shown to decrease retinopathy. And other lipid-lowering agents might also lower retinopathy a little bit. Now, this doesn't mean that this is going to be the primary treatment of retinopathy. By no means is that so. So it's part of the way we manage patients, looking at all aspects. Look at their lipids, look for side effects of their other diabetes medications, look for the lipid-lowering, blood pressure, ACE inhibitors, and other drugs like that might have some protective effects. So we've got to look at the patient as a whole.
Wonderful. And one last question for Dr. Karpecki. Paul, question from the audience. Patient has both cataract and diabetic macular edema. How should that patient be handled?
Yes, good question. We see that a lot in our clinic, and and the advent of OCT has really allowed us to see how common that is. Many of these patients have very subclinical. They're definitely present, and once you do an OCT, you find it, but they may not have been visually apparent to someone like me, even though I look at a lot of retinas, it may not have been as visually apparent until these newer technologies came available. Now, as a retina specialist, you might have picked up on these subtle cases, but the OCTs really helped us to realize that many of our patients going in for cataract surgery, especially diabetic patients, will have subclinical or cases of DME that are present, not even subclinical, but truly there. And so what fascinated me is their vision might not have been as affected. We kind of pointed to the cataract being the cause. So this is a common question, a common finding, I should say, a common occurrence in clinic, so it's an excellent question. That being said, yeah, you got to control the macular edema first. That becomes very important for a number of reasons. First of all, it can affect even our biometry when you're trying to take measurements and get your alignment and figure out the IO calculation. Any sort of edematous change, corneal, macular, or otherwise, can throw those readings off for us a little bit, and you end up getting a surprise result if later on you should actually treat the DME. The second thing is really important too is for patient outcomes. If we don't take care of that first, and even if a flawless cataract procedure is done, the patient may say, wow, I thought my vision would turn out a lot better. I had friends who had cataract surgery. They talk about how well they see. And then you're having to try to explain there's something else going on to much greater extent, and why, without treating it ahead of time, it just affects those kind of outcomes. And and then even more so, if you look at I think from a perspective of what's more critical in terms of patients in prioritization, I still think that you got to get the DME and that controlled well as a much more important initiative, so to speak, because that is something that's present, that gets overlooked many times, that's going to affect their vision, and can actually progress. So the issue with cataracts, it is a bit of an elective. We're not talking about hyper mature type cataracts anymore, so there's not an issue to wait a little bit longer to just insure it. On the downside, certainly, in the past, when we used to have to consider, laser treatments, certainly having a clear lens would have probably helped, but we're not talking about that today. We're talking about these anti-VEGFs are our first line of treatment, as we saw in the Protocol T results, so that's no longer an issue. So I would, for one other reason, I recommend the DME be managed first, and then once controlled, then consider cataract surgery. And you'd be surprised sometimes. I've had patients whose vision wasn't as dramatically down. It was more DME related than the cataract, and they were able to wait a year or two. So a number of good reasons to kind of take that approach to taking care of the macular edema, and then once that is resolved, consider the cataract surgery.
Right, wonderful answer. Well, we're a little bit over time here. I want to thank all the participants, Dr. Moshfeghi in Los Angeles, Dr. Fonseca in New Orleans, and Dr. Karpecki here in Lexington. I want to also thank MedPage Today. I think the take-homes from this DRCR protocol, that we're very fortunate to be in an era where we actually have wonderful treatments that are available to our patients. I think the decision on how to treat patients should always come down to a physician-patient decision collaboratively, and unfortunately I think sometimes it gets dictated by insurance companies, and that's where studies like this hopefully will come to help support the rationale behind how we use these agents and why we use these agents. And then finally, to bring awareness to diabetic macular edema, a condition along with diabetic retinopathy that is still going unrecognized and underserved. So thank you all for joining me, and have a good evening.